I am now pleased to kick off our event and introduce our first speaker, Lisa Kane Lowe. Dr. Lowe is an Associate Professor and Associate Dean for Practice and Professional Graduate Studies in the Department of Health, Behavior, and Biological Sciences at the University of Michigan School of Nursing. She's also the current president of the American College of Nurse-Midwives. We're so honored she's with us today to discuss maternity workforce challenges and how we can support midwives. Dr. Lowe?
Thank you. And as we move into the next slide, it's my pleasure to be a part of this really incredible panel to be able to bring awareness and thoughtful consideration to where we might go in moving forward in addressing the maternity care provider shortage in this country. As we start the panel off, I've been asked to just provide some background, and so in an effort to do that, I'm going to just offer some context for how we're looking at the concerns and the gravity of it. As we look at the number of women who will be needing services, in essence what this slide is telling you is that there's a growing number of women of childbearing age who will need care over the next several decades, and that as we're seeing that growing need, when we map that against what our current provider availability is, what we see is that ACOG, the American College of Obstetricians and Gynecologists, when they look at where their physicians are located, we can see that almost 46% of the counties in this country don't have access to an OBGYN physician provider. And at the same time, we have some maldistribution in where the providers are. In addition to looking at the role of obstetricians and gynecologists, we can also compare that to availability of another part of the maternity care workforce, certified nurse midwives and certified midwives, which are represented by the American College of Nurse-Midwives. And using the same approach to looking at where we have midwives in this country as certified nurse midwives and certified midwives, we have some of the same challenges with the distribution and availability of them, with almost 56% of the counties in this country having no access to a certified nurse midwife or certified midwife. And when you map those together, what we see is that we have a number of areas, particularly rural counties, that don't have access to members of the maternity care team in the form of a midwife or certified nurse midwife, certified midwife, or an OBGYN physician. And that we also have continuing challenges with the distribution, where high density in some areas and then zero access in others. In addition, the other member of the maternity care team, family physicians, what we're seeing with the family physicians is that they're having less of a role in the total number of individuals they attend during birth. And as they decrease in their presence, they're not only decreasing in total number in terms of the types of settings they're in with high volume deliveries compared to low volumes, but the total number of family physicians participating in OB care has also decreased. So combined, we've got a smaller total workforce providing maternity care. And when we map that against the number of individuals in our pipeline and look in particular at first-year OBGYN residents and new certified midwives or certified nurse midwives, what we see in the distribution is that the number of OBGYN residencies is relatively static despite the growing demand and the concerns about distribution. And the growth in nurse midwives and certified midwives, while it's been slightly increasing, in total they represent about half the workforce that graduates each year to provide women's health care services. So in total, when we put all of these pieces together, what we see is that we have a static number of graduates by and large in OBGYN, and my colleague from ACOG will also be speaking to you more about the distribution of those providers, but a number of them go into subspecializations, and the number of midwives are increasing, but still at a smaller rate than the workforce demands would suggest are needed. We're seeing some changes in our provider demographics that are leading to different durations of time in practice at the same time that we're seeing this increasing need. So taken in total, as was provided by the introductory remarks, we're facing a significant and substantial shortage in the number of skilled providers who are able to meet women's health care needs for maternity care services. Now, just to offer a little bit of background on who I'm speaking to today in terms of the role of midwives as represented by the American College of Nurse-Midwives, certified nurse midwives are individuals who are educated in the two disciplines of midwifery and nursing, and they're graduate prepared and complete a national certification exam offered by the American Midwifery Certification Board. They become then a certified nurse midwife with those two disciplines. In addition, taking the same national certification exam are certified midwives who are educated in the discipline of midwifery and earn their health credentials through their graduate degree as well and become certified midwives. Taken together, that workforce represents just under about 12,000 certified nurse midwives and certified midwives in the United States. Certified nurse midwives are licensed to practice in all 50 states. Certified midwives are licensed in only 5 states with a growing emphasis on encouraging access to licensure. An additional member of the maternity care workforce are certified professional midwives, and they're represented by the National Association of Certified Professional Midwives. So I'm not going to be speaking to them in terms of the role in the workforce specifically today, but they represent midwives who are licensed in now 28 states, and they provide care primarily in the setting of the home or birth center. Some states may also license midwives who are not represented by one of those 3 credentials, but who have state-based licensure. So there's some people refer to it as a lot of alphabet soup, but the key point that I want you to take away from this is just that there's variation in who's able to contribute and in what states to the maternity care shortage issues and development of an expanding workforce. What we do know about the role of midwives, though, is that a number of national and global studies have been done to look at what the contribution could be if you have access to educated and licensed midwives. And essentially, what is the takeaway from this slide is to put an emphasis on the fact that we can provide as midwives a significant amount of the care needed for women and newborns, and yet our distribution is the flip of a triangle when you look at a number of available midwives for contribution to the workforce compared to OBGYN physicians. And so thinking about the ways in which we provide our model of care and work together is something that I'll discuss a little bit further as we go on. What's important to think about in terms of the role of midwives is what their scope of practice and role is. And midwives who are certified by the American Midwifery Certification Board as CNMs or CMs provide the full range of primary health care services for women from adolescence beyond menopause. And these services include primary care, gynecologic, and family planning services, in addition to the maternity care support, as well as treatment and care of newborns through the first 28 days of life. So the scope of practice that midwives who are CNMs and CMs are educated to provide extends this full range of services and represents what is a significant amount of what many women will need in their lifetime. When we look at how to provide that care, one of the things that we want to think about is getting the right care at the right time in the right place by the right providers. And there's a different way that we can think about accomplishing that when we look at our workforce. Midwife-led care can really be independently provided care to individuals who are healthy or sometimes referred to as lower risk. individuals who might have certain health conditions that require different levels of specialization may be provided care in a model that's jointly led by physicians and midwives, where consultation and collaboration is a part of the role. And then there's other individuals who clearly will benefit from physician-led care because of the specialized services they may require or the unique needs that they have. But taken in total, the opportunity to provide interprofessional collaboration is really an ideal model that could contribute to expanded scope of resources in our workforce. But when we want to provide this care, one of the things that becomes a significant challenge is the laws and regulations that may affect access to maternity care. And in particular, our laws related to scope of practice. And in each state, there's variation in what midwives are licensed to be able to provide and the ways in which they need to provide that care. The goal for ACNM in supporting midwives in their practice environment is to have what is referred to as full practice authority. And that's basically letting midwives who are CNMs and CMs be able to practice to the full extent of their education and training, with independent licensure that doesn't require supervision or legislate collaborative agreements be part of the necessary contingency for them to be able to practice. And this approach to the practice model is in alignment with the joint statement of practice relationships between obstetrician gynecologists and certified nurse midwives and certified midwives as approved by our both of our boards. And that's that we're independent providers who are working together in a seamless, collaborative context in order to provide the services that individuals who seek our care need. And when we look at the way that full practice authority looks across the country, interestingly, what you see is a wide distribution where we currently have now, as of this summer, 28 states that allow for independent practice of certified nurse midwives and certified midwives, and then a number of others that require collaborative agreements either for prescribing ability or for the ability to practice. And some states that are considered the most restrictive require supervision, all of which prevent ready access to midwives as care providers and are linked to other distributions of where you have access to reimbursement for those services that you can provide. When we compare the state practice review to the number and density of where midwives are practicing, we start to see patterns where you have the highest distribution of midwives in areas where they have full practice authority and can fully provide care and services consistent with their education, and less distribution in states that have more challenging or restrictive requirements or barriers to practice. Often the concern when we look at scope of practice and distribution of providers is that somehow the linkage between scope of practice and supervision will tie into health outcomes. And one of our colleagues on this panel has actually conducted some important work that looked at the question of what happens when you have scope of practice laws that support autonomous midwifery practice. And what we learn is that when you have autonomous midwifery practice in states, you actually have more births attended by midwives in those states compared to states with more restrictive agreements. And you also see that in the more autonomous areas, having midwives be a part of the larger workforce to provide care and services also is correlated with improved health outcomes focused on reduction of cesarean section, improvements in preterm birth rates, and in low birth weight. So that we see a tie-in when you can practice to the full scope of your training and education with supporting improved access to a maternity care workforce that also contributes to improved health outcomes. So state practice laws become a primary focus for how we could improve our workforce and access to midwives in particular as members of the maternity care team. We also know that the way that we educate and train midwives and physicians could be further expanded to support more collaborative work in our educational settings. And we currently have a pilot project which is funded by the Macy Foundation with ACNM and ACOG to work together to develop collaborative practice opportunities for the curriculum of our residents and midwifery students. In this project, we have 4 demonstration sites, and the interesting piece of this is that not only are we trying to do the direct care changes in how we do the education, but we're also changing the accreditation requirements by engaging all of the agencies that work on accreditation of education programs so that they recognize the joint way that we're collaborating to do this work. So we see this as a real opportunity to expand the workforce as we expand the number of sites where we can practice together, providing the right care at the right time with the right provider. Other areas that we see as opportunities to develop expanded workforce is to really target rural settings with educational training. And we have a number of examples in the education programs for nurse midwives that focus on rural needs. One exemplar is Frontier Nursing University that currently enrolls about 50% of the students who are graduates each year, and they have specific curricula that support access to and providing services in rural settings. So more opportunity to scale up these types of model programs is something that we think will be really useful. And then a couple other highlights of areas where we think we have opportunity to expand the workforce include using, similar to having graduate medical education models where the training site is in the hospital setting and there's reimbursement and support for those services, the same can be applied to nurse education. And there has been a demonstration project that's looked at doing this, but only with 4 small hospitals. So we hope that this will be something that has good results and that could, again, also be scaled up in the same ways in which graduate medical education is done. Another opportunity is to look at who's available to train and support growth in our number of students, which requires having more preceptors who are available to train our students in the clinical setting. And there's an interesting opportunity in Georgia where they are providing education and precepting and giving tax deductions as an exchange of service and recognition of the contribution that these individuals who are precepting are making to the education of those who are providing maternity care in the future. And then another final example is that as we look at the ways that we are supporting training and education, we have to encourage more collaborative models, which includes the IPE training that I just highlighted from the Macy Foundation, but it also includes the ways in which midwives are engaged in supporting the training and education of our physician colleagues as they're learning to do lower-risk, healthy maternity care. And currently, we are advocates for legislation that would provide coverage for when midwives provide education and oversight under the GME model for residents in their training programs. And so these are just a few examples that we can think will be ways to really expand the numbers of individuals coming through the pipeline. And at the end, I would offer that as being someone from the University of Michigan with several degrees, I often think of the team as a critical quote in how I want to approach challenges and problems. And when I think about addressing the maternity care workforce shortage, collaboration is the theme, and I think you'll hear more exemplars of that as the rest of the individuals on this panel move forward in their presentations. So I thank you for your time and look forward to any questions that we have as we move through the process.